All right. Welcome again, everyone. My name is Stephanie Basong, and I'm joining from the American Telemedicine Association. Thank you all so much for joining today's webinar, The New Era of Care, Evolving Leadership Structures for Virtual Care at Scale. This webinar is sponsored and hosted by ATA member Avasure. Just a couple of housekeeping items before I hand things over to today's moderator. This webinar is being recorded, and the recording will be sent out and will be available for future viewing on the ATA website. And also note that all webinar attendees for this session are in listen-only mode. So if you'd like to ask any questions, please use the Q&A function. We encourage attendees to ask questions anytime throughout the webinar. And without further ado, I'd like to turn this presentation over to today's moderator, Ann Mon Johnson, the CEO here at the ATA.
Thank you, Stephanie, and hello, everyone. It is really a pleasure to be here with Lisbeth and Malik to talk about the evolving leadership structures for virtual care at scale. It's really an important topic. And one of the really exciting things that I have at ATA when I do these webinars is I get to do a mini deep dive on a topic of keen interest and importance. So thank you. I really want to thank Avasure in particular for their partnership and leadership and innovation, including their support of the Centers of Digital Excellence Code, which was announced at the end of last year. It's really been a growing and important effort with our different members across the delivery systems. And I also want to acknowledge that Malik Khan, who's on the panel today, is a very engaged member of the ATA and member of the Clinician Council. He's the medical director in virtual health and virtual ICU at Corewell in Michigan. So I have not done a great job of introducing either of you. So I'm going to turn it over to you to do exactly that. Lisbeth.
Thank you so much. I'm really excited about this topic. I'm Lisbeth Retruba, the Chief Clinical Officer for Avasure. I am a third-generation nurse, and I have been solely focused on virtual care for the last 10 years of my career. And through that, I've had the privilege of partnering with many health systems across the country. And from that vantage point, I've gained insights on various leadership structures in place to support the implementation and growth of virtual care. And it's such a highly functional leadership team is fundamental to being successful. And as the title says, it's virtual care at scale. And I don't think we talk about it often enough. So I think that's why this webinar is super popular, and we've had a lot of registrants. So very excited to have this conversation with Dr. Khan too.
Thank you, Elizabeth and Ann. I'm also super excited to be here. I'm Malik Khan. I'm a MD pulmonary critical care physician. I've been with my organization, Corewell Health, for the last over 7 years. My journey with telehealth and virtual health formally started when I became the medical director for our virtual ICU. And Corewell is a very progressive and innovative organization. I'm lucky to be a part of it. And we had always been involved with virtual health and telehealth-based initiatives. But as we will discuss through the course of this, as times evolved, we started becoming more deliberate in our governance and leadership for the virtual health. And I rose up and became the medical director for virtual health. And in that role, have been able to oversee a lot of the new initiatives, try to get a lot of these multitude of processes that we umbrella under virtual health to move forward. And very excited to discuss this. I have, over the course of the years, I have had discussions with multiple other physicians and leaders at other healthcare systems trying to figure out this exact question. What is the best or ideal leadership structure for virtual health? And I haven't gotten a single best answer. So we've all been trying to figure it out as we go. And I think during that here today to share some of those learnings and help everybody else figure this out with us.
Yeah, that's great. Thank you so much. And I think that what we're learning is that as virtual is less of a sideshow and more the fabric of how an organization operates, that really leadership and governance is how this is done well and how it's really integrated into high quality and connected care. So I think that's why it's an incredibly important conversation. So for the audience who's listening in, again, we have time for Q&A, so please post your questions. And it may be that we respond to them during the course of the conversation, or others will save to the end, but don't be shy. The conversation is being recorded, and we will be able to make that available to you shortly after the conclusion of the presentation and the webinar. So let me start first by asking both of you, how have leadership structures evolved to support virtual care? And even if we start with pre-pandemic to post-pandemic, and can you comment on how they've changed? Because I think that's an interesting vantage point as well. Who'd like to go first?
Elizabeth, you want me to
Yeah,
take?
I'm happy to go first. And like you said, Anne, virtual care has really come of age. And I think the shift that I've seen over the last 5 to 8 years is a shift from being kind of single use case niche, best in class kind of technology solution to something that has to be a virtual, like an enterprise platform with a capital P, with that's scalable across multiple use cases. And so back in the kind of early days when it was just single use cases, the leadership structure was, naturally more siloed. And I've been doing this 2009, I think, is when I first started on the health system side. And some of the leadership might come from an innovation center of a health system, or even the investment arm of a health system, bringing in kind of a small pilot, and it would grow from there. But now it has to be a much broader strategy with a broader coalition of stakeholders to support it. And I just noticed in your introduction, Malik, you started in a specific use case, which was virtual ICU, and now you're the director of virtual health, which is such a broader title. So I'm sure you've personally experienced this in your years.
Right. Exactly. And I completely echo. I think the way that this has evolved was, I believe that most organizations, or a lot of the organizations, had been involved with a lot of what we call bread and butter virtual health, telehealth visits, and so on and so forth for a while before even pandemic hit. Pandemic just hit the accelerant on a lot of things. ICU being an example as well. We have had tele-ICUs for 2 decades, right? And it's not that this just started. But what was different, I think, was back then, these were not considered system-wide initiatives. These were individual initiatives, somebody coming across a particular use case, like you mentioned, Elizabeth, and then running with it. There was no specific form of governance attached to how those were vetted, how those were eventually implemented, how those were followed. It kind of became the responsibility of the department that was, or the clinical service line that was leading those. As we have evolved and as we are evolving going forward, I think one of the changes that we are seeing is that organizations, healthcare systems are recognizing that there are learnings to be had from implementation of these virtual first telehealth based initiatives, and those can be more generalizable. There is need for dedicated, deliberate governance, and there is need for funding, right? Because one of the things that was funding was never assigned to this whole telehealth process. We've always talked about service lines or departments coming up with the funding that is necessary, but we know a lot of these initiatives are capital intensive. So moving forward, having their own deliberate governance structures, you can associate not only operational resources, clinical leadership resources, but also funding resources that can help make it easier to move these things through.
It's interesting. I'm hearing both of you. I'm listening to both of you, and it really sounds like that it's a much more formal structure now than it has been. And with that, with that formality, it really becomes a core modality and an operational approach. So I'm assuming both of you would agree, because I think I'm really picking up on that theme from you. So can you talk a little bit more about this in terms of what new roles or leadership models have emerged? And I'm even thinking about the new titles that have come up in the last several years. Malik, you want to take that first?
Sure, yeah. I mean, the simple one is that you will now see a chief medical officer for telehealth, right? That is a newer title that has come up in this space. And the reason for that is I think a lot of organizations have understood that, like any other enterprise-based system that is going to be implemented, which has both clinical, digital, operational elements to it, you need leadership that represents all of those aspects as well. So having the couple of things that I think we are talking about in this formal leadership structure is, one, having somebody start from the very top. Like you need access to the C-suite. When you're talking about telehealth and the decisions that are involved around implementing system-wide telehealth initiatives, you have to have somebody be at that seat where these decisions are made. So a title like Senior Vice Medical, SVP, CMO for telehealth, along with their operational dyads. I think those are the things that we are seeing come up formally.
Yeah, I was just at a conference, CNIO conference in DC last week, and they were all, I think a theme that came up is like, hey guys, we're not just in charge of EHRs. Our role is much beyond that now. And they also need to be key in the governance of virtual care. And one role that I think is phenomenal, and I think it goes to your point, Malik, like UC Health in Colorado, they may be the first to have a chief nursing officer of a virtual health center. So Amy Hassel has the title of chief nurse, and she is on par with the chief nurses of the 15 hospitals. But her hospital has no actual patients in it. It's a virtual health center. But they have, all across the continuum of care, from virtual ICU to remote asynchronous remote patient monitoring and everything in between. And then you mentioned dyad, so that kind of that collaborative role between the clinical leader and operational business or strategic partner is becoming more and more common. And I think the dyad partnership is like 1 + 1 = 5, because you bring in those two perspectives, work very closely together, and really excited at ATA Nexus coming out. There is a panel about dyads, and just prepping for that panel. Everyone loves their dyad relationship. So, and it seems like a very effective model, role in leadership model.
Right.
Well, and it really leads to tighter alignment, doesn't it?
Yeah.
Yeah, I was also going to say that there is, I think we'll get into the details of it later, but I don't think there is one prescribed model that you can say that this is how it will be. Like you said, Elizabeth, there are the organizations that have a chief nursing telehealth officer. There will be organizations that have chief medical officer for telehealth. What that points towards is that this is not a structure where you can miss out on your clinical leadership, which is nursing and physicians, and you cannot miss out on your partnerships with your digital health team, right? So
yes,
one of the things that we have done at Corewell is that, keeping this in mind, we have more of a care delivery digital governance model. So we don't just have one singular leader, we have a group of senior vice president level people who sit in this governance model, where we have representation from our clinical teams, our operational teams, nursing teams, rev cycle, we have legal and compliance, we have digital health, because if you are going to make decisions in a timely manner and have those decisions be vetted appropriately, I think you need cross-functional representation. So that's one of the things that we as an organization thought would be the right way to go. And so far, it's been working well for us.
And are you seeing similar approaches with other organizations you work with, Lisbeth?
Yeah, on that, I think it might feel counterintuitive that if you put in governance structure, more committees, some of us cringe at that and we think, oh no, we're going to get bureaucratic and we're not going to be able to make decisions quickly. But in this case, I think it's really the opposite, because if there is no governance, whether it is kind of a single leader, like there's starting to be more chief artificial intelligence officers on the health system side that might be just kind of a single point of decision versus a committee over something like that. But if you don't have that, it just leads to multiple veto points across the health system, and and progress actually freezes. So very interesting. We did a panel on getting out of pilot hell to actually scaled, and we had two health systems, one in the West Coast and then one kind of in New Jersey, and they each had a different approach, but they did have a formal leadership. The one in the West Coast was very much strong executive leaders who set the strategic direction, had the vision, and helped march in that direction, and leaders who understood they needed to get the buy-in from the bedside. The one in the East Coast, they were expanding their virtual nursing across the whole system. They'd done a pilot. Now they're at 4 hospitals. They'll be at 5 hospitals next month. And they had 5 different committees that worked together at the same time to make sure this happened. And it sounded complex, but I can see that it's working. And they're scaling. And they're scaling.
That's good. We actually have a question that allows both of you to drill down if you want from the audience, and that is, what roles are necessary for a minimum viable product model early on, and what roles are necessary for a larger and more mature model?
Do you want to take that, Molly?
Right. I mean, I'll take it. I mean, I've been advocating for this at my organization, and as I said earlier, I think in my mind, when we look at something like this, we do need a singular, strong clinical leadership, because most of these initiatives have a very strong clinical flavor to it, right? Whether that's a nursing-based, when you talk about inpatient initiatives, a lot of those are to do with nursing initiatives. When you talk about outpatient, there's a lot more physicians. So I think this chief medical officer for telehealth is becoming more and more of a necessity rather than a nice to have role when we talk about formalized governance. So I think that then having a dyad, which is a strong strategic operational leader, an SVP or a VP of telehealth would be the minimum start in my mind to build a structure that would work for that organization. Now, with that being said, the reason I said this is not something that can be prescribed. When we talk about healthcare organizations in today's day and age, when we talk about large healthcare organizations at scale, a lot of those are being built by mergers, acquisitions, taking up other smaller healthcare systems that come up with their own governance structures. And that is why this has been a bit more challenging than some of the traditional clinical service lines with their leadership structures, is because virtual health, in my mind, does not sit vertically. It sits horizontally across a lot of your other clinical service lines and processes across the healthcare system, whether you silo it out into inpatient and outpatient or hospital and ambulatory based care, or you silo it down as individual service lines, cardiology, gastroenterology, OBGYN. You're going to need a leadership structure that can talk across those service lines, because you will be embedded in all of those. So I don't know if I gave you the ideal answer, but I think to start out, you need a chief medical officer and a VP or SVP for operational to start helping you build that structure for you.
And I can give an example of maybe a very successful smaller organization, because Corewell, you just did go through a big merger, and you are the biggest employer in your state, so that's kind of a larger health system example. We have a very successful partnership with a more rural health system that has just a few, like a flagship hospital and some critical access. And they have a great virtual care program that works for them that improves access for patients and helps them keep those patients out in critical access instead of, transferring them in. But that is really led by people who are wearing multiple hats. The CMIO is a leader there, and there is a nursing director who has a passion for it and has enough time carved out in his schedule that this is part of his role to lead this. So I think you don't need to have, and not everybody has a luxury of people who 100% of their role is focused on virtual care.
So the next set of questions are on dealing with silos, which is something that we've had to contend with in healthcare quite a bit. For example, inpatient and outpatient used to be very separate. And is that still the case in this new model? And how does governance and leadership structures, how have those changed to accommodate a more holistic approach?
Like, as I said, I think in our case, we, because of this reason, we came up with what we call the matrixed governance, right? So it is this governance structure with a digital delivery governance committee, which has leaders from all these individual, so we call them, in our organization, we call them clinical service lines. And then we have value streams, which are run horizontally across these service lines. So we recognize that we cannot have virtual health just be one of the other individual silos. It has to be a pillar that connects them all. So yeah, I think we are, as an organization, have been deliberate about building a structure which incorporates and allows leaders from other service lines and other hospital processes to come in and be available to vet, to run, and then later on implement these projects that we bring forward.
Yeah, I had an aha moment, and when we were prepping for this, and so I come with a nursing background, and Molly comes with a physician background, and I realized I sort of think about this on acuity. So I think about, home, outpatient ambulatory, maybe ED, then med surg, then intermediate, then critical care, from acuity. And Dr. Khan was kind of looking at it by service line, and even kind of, I know you're mentioning like there's, I think you were saying like there's oncology, there's maternal child, there's pediatrics, so almost like more of a medical model. And I think that's a really good example of how we do have to break down those barriers between different disciplines, because we even speak a different language, but we really were talking about the same thing. So and that's what, and then it becomes it gets better, if we all kind of bring our perspective together, then you end up with a better outcome.
Anything you want to add, Malik? You look like you were about to say something.
No, I was going to say, yes, that is the language or the how we talk about this. That is not, unfortunately, not unique. It's unique for other healthcare systems as well, right? So that is just an issue with the overall leadership structures in large healthcare organizations. One of the issues with having telehealth be siloed into equity-based services is that a lot of times we have follow the patient from when they are in the ICU, then they leave the ICU to go to the regular floor, but then now they're going to, so if we try to deliberately design products or services or solutions that would focus on just when they're in the hospital, but not communicate with the products that we're going to use when they're outpatient, or if they're remote patient monitoring products and solutions we are using cannot deliberately work well with their inpatient stays. That is where some of the benefits of telehealth can break down. So I think when you're designing this, keeping in mind that you're going to be using telehealth across all these different levels of care that a patient comes across in their healthcare journey.
Well, and as we all know, the care doesn't start or stop at the hospital door.
Exactly.
Yeah, and that's pretty exciting because virtual, however you refer to it, digital, virtual,
Mhm.
it really helps blur the lines, as my colleague Alyssa Baker says, in a good way. So I appreciate that. We sort of touched on this, but maybe we could talk a little bit more about what strategies have you used specifically at Corewell, as well as you think about this more globally, Elizabeth, what strategies have been effective in optimizing clinician engagement? You've talked about a couple, but maybe you could just drill down a bit.
Right. So being a clinician myself, I think one of the things that we have to keep in mind is there is a lot of inertia when it comes to adoption of, and this is something we talk about in the telehealth circles all the time, right? We are trying to build faith and trust, not in just the new technology, but in the new modality and a new way of doing things when we start talking about utilizing telehealth in the healthcare space. And we haven't had the luxury of the amount of data that we have for our regular traditional healthcare that now we're starting to build for telehealth as well. So whenever I talk about optimizing clinician engagement, I always come from it from a point of view that I want to make sure that the folks that I'm talking to, I'm letting them know that this is something that will help not just improve the quality of care that they will provide to their patients, it will make their physician, clinician, nurses, their lives easier. It'll make them more efficient, and it will help them be able to do what they are doing best, which is taking care of their patients in a much more cohesive and efficient way. So in our strategies, we focus a lot on physician well-being or our provider well-being. We focus on nursing well-being. We try to tie the telehealth strategies into some of these other pillars with which we can help them show the benefit to the clinician team and help them be part of this process. Elizabeth, what have you guys seen in other?
I'm really optimistic about clinical engagement with virtual care. It's transformational in the way that the electronic health record was transformational 15 years ago. And I think we learned lessons there. I think we all learned that if you're not part of the change, if you're not at the table, it gets done for you, and that's not the best outcome. And this time around, as I sound old, but I really see clinicians wanting to be more engaged, and even professional organizations, whether they're, physician specialty organizations, like ATA is a great example, helping to form coalitions, and so that, we don't have an individual, just the Academy of Critical Care Physicians is just going down this one path without kind of broader engagement across all. So I find it an exciting time to be a leader, a clinical leader.
Yeah. So, but let's push on that a little bit more, because you touched on it, the EHR implementations, and that was more of having people do to you as opposed to do with you.
Yeah.
And I'm wondering if there are other learnings from EHR implementations in the past that you're now saying, oh, this is something that we learned that we will do differently, or we will continue, as you think about the whole virtual care and how that gets reflected in governance structures and so forth.
I'll have one quick example while you're thinking. And this ended up being a very elegant solution, but there were nurses at Kaiser, unionized nurses that were protesting against AI sepsis alerts. And now you don't hear so much about it, but they had a really elegant negotiation and solution that ended up being a win-win. And it was including clinical nurses, frontline nurses on the AI governance committees. And that was the compromise. And that, and of course, decisions are going to be better because of that too. And they feel empowered. And so I think that's one example. I don't know if you have others.
I don't have a direct example, but what we are doing in our organization is that we are identifying leaders, like clinical leaders in individual spaces that we call are the super users, so as to speak. And we are using them as test cases and helping them be the voice to their colleagues as to how when they utilize one of the telehealth technologies, instead of rolling it out across the board, we're using that strategy where we choose a group of people, help work with them, work out the kinks. The last thing I think that really dampens the progress in telehealth is when we start doing things and we have not thought about the issues that come up, because issues will always come up when you roll this. As much as you can mitigate that, like you said, Elizabeth, involve the people that are going to be the front end users of providing that care, using that technology, be part of designing some of those. That is why we mentioned since the start that having clinical leadership is extremely important as well, that you're not just having somebody tell you what to do, but you're involving somebody who's doing that, working with you, building what they're going to be building, whether that's a program, whether that's a new technology that is being used.
I think I heard you talking about fail fast and being able to, and there was a great example of that recently from two of our partners who were starting virtual nursing, and both of them, like separately, states away from each other, started with this idea that the virtual nurse would triage call lights. And it was a disaster for both of them because then it just ended up like the virtual nurse really couldn't respond to most of the call lights. And so they were then, chatting to different people, and it ended up just making the work much more complex for the front line. And both of them abandoned it real quickly. And I think that gains trust that that the frontline clinicians can say, if we raise an issue, the leadership is going to be responsive to that right away.
Right.
It's
On
okay
that,
to
like,
say, okay, that didn't work.
right. You've heard me say before, right, that the healthcare organizations have a lot of inertia when it comes to implementing new things and or moving away from things that they've implemented but haven't necessarily worked well, just because of I guess the stakes are considered to be too high. When I compare ourselves with other large digital organizations, your Microsofts, your Apples, that is a key difference and then when we are talking about telehealth, we are moving closer to that model. We are trying to merge the traditional healthcare model where we are very deliberate with everything we do, want to be extremely fail-safe, to moving to a more innovative model where you know that some of the strategies, some of the products, some of the innovation that you will go for will necessarily not work out as it. And then when do you decide, like you said, how do you decide to move on? So that is why that, to tie it back in together, that is one of the reasons why the leadership in a healthcare organization has to be from the top, starting up, so that if and when you come across something like this, you then have the ability to roll back something that you may have spent a lot of dollars on. Right? It is not going to be an easy decision. It is going to be a tough one, but eventually it will pay off.
So I'm going to remind our audience that we are going to take questions and happy to take them during the course of the conversation. So please use the Q&A and not the chat to put in your questions. One area we have not touched on, but this is sparking an interest because you talked about a focus on well-being at Corewell, and I'm assuming clinician retention and so forth. What are some metrics that you see consistently emerging, and what are some metrics that you're sort of puzzled that they don't come up? as you look at what good looks like. Yeah.
Right. I mean, we recently implemented an AI-based note-taking software that we piloted with a couple of offices. It was a huge success, and we looked at a lot of metrics. One of the ones that we focused on was what was called pajama time, as to how much time physicians were spending or providers were spending after they were done taking care of the patients, than just finishing notes or working with the EHR or EMR for things that are not necessarily directly patient care. And we saw huge improvements. So like the first time I heard about it, I'm like, that's not possible. How much time were people spending on a daily basis? This was hours of time saved. And we implemented that in a matter of months. And there was a huge, people were literally asking for more licenses for these. And we are continuing to follow that. We're still looking at it, and we've noticed that people are getting off of work earlier. We're able to actually see that some of them are able to open more slots, so increase access to care. And just generally, we are all of our surveys that we do, Glint surveys, they're showing that people are happier with their work-life balance just by the implementation of this one tool. Again, we are getting into the realm of AI, and I know heard Elizabeth, you talk about it. It's that is why the leadership for telehealth has to be cross-functional in that sense as well, right? That you will have probably a separate leadership structure, like we have this AI Council of Excellence, and we talk to them closely to make sure that the products or the services we're going to implement work well with us. So another example of where the telehealth, digital health governance structure will have to be not just working well with your other clinical service lines or areas, but also with your AI teams, your innovations teams. We didn't talk about that, but at Corewell, we also have an innovations team, which works very closely with our telehealth team to try to, whenever one of the things I joke about is that the number of emails I get about new products that are coming to market that have this breakthrough that can be so good for our patients. If I just did that would be like 3 times the work that I do. So you have to have deliberate systems of how you can appropriately vet these and then run them through our innovations department to try and see which ones would work. And if some of them need a piloting, we partner with those organizations or those our partners in the industry to try to bring them to fruition.
Mm-hmm.
And getting back to your question about workforce well-being, that's an awesome question. And on the nursing side, I think many health systems look at their NEAT data, and I don't remember what NEAT stands for. I'm sure people could put it in the chat who know, but it's basically the amount of time per shift somebody who works on salary like that is spending in the electronic health record. But there has to be a balance with that. Generally, you would assume less is more, but you want to make sure that they're just not doing quality documentation. So if your health system is winning because we barely document at all, you might be missing some key quality data capture, and so that it has to be balanced. But the second part of your question, is there anything missing that you're surprised isn't more of a focus? And I have a soapbox on this one, and this is workplace violence prevention. And so if you think of Maslow's hierarchy of needs, safety is at the foundation, and our health caregivers are really increasingly at risk of workplace violence. And I know that nursing assistants is they experience more intentional violence than any job category in the US. And so what are we doing and how are we tracking that? It's not well tracked. I think, first of all, it's not well reported. Verbal abuse isn't really what ER nurse has time to, or ER physician has time to document all the verbal abuse they experience. So I think that we could do better on that, aside from just the injuries that happen. That's the
Mhm.
end of the, so I would love to see that measured better. And I have published some studies and research on that from what we've gathered from our database on what's happening in emergency departments in hospital rooms. It's alarming, and it's going to get worse before it gets better with capacity issues in emergency departments and cuts to mental health spending. So I hope that's something that we can all focus on more. And sometimes it's appropriate to have virtual care rather than put an employee in harm's way.
Right. Yeah, no, absolutely. We just got a question that I think you both would appreciate responding to, which is, are you seeing healthcare systems restructure virtual care leadership to ensure accountability for care, quality, outcomes, and financial performance?
Right.
Liz?
That is a great question, actually, because that is one of the things that I feel even in my practice, when I was just the role of the medical director for virtual ICU, we didn't have like the resources that we needed to be able to do good data collection and measuring the quality of care that we perform, just because of the the kind of work that we were doing, right? We were working in these different regional ICUs to collect data from all of them. It was not. So one of the things that we do when we are building our structure up is we are deliberate about it. We also have a clinical excellence governance structure as well, where I sit as well. So that is where we at that level, at the highest level, we talk about some of the initiatives with our chief quality officer as to what are the things that we have to focus on, and then be very deliberate about how telehealth can actually help support some of those processes and be a part of the solution rather than once you've implemented it and then be like, oh, this didn't turn out to do any good. So I think, as to answer the question, large healthcare organizations should be very deliberate. And one of the ways to do it is to then tie it in with your chief quality officer or have them have a seat at the table or somehow collaborate with them through that process. We do it through our clinical excellence governance.
Absolutely. And you mentioned the Center for Digital Excellence, the code that ATA sponsors. And this is kind of a hot topic there. And I think there are like 12 or more health systems participating there, and they're leaders in virtual care. And they are all getting in different ways, but pulling quality and finance and into the governance structures. And sometimes that means that the formal org chart looks different as well.
Mhm.
So kind of dotted lines over to quality and, direct lines through clinical. And so a lot of different ways that that's happening. And I actually think the Center for Digital Excellence is going to be producing a white paper on that specific topic. So we could get some specific examples of how those health systems are doing that.
Perfect. Perfect. Thank you for that. And again, thank you to Avashore for your support of CODE, Center of Digital Excellence. We have another question that came in that perhaps you guys want to touch on. How do you prioritize, and this is a little bit into our last question of what advice do you give to people who are early on in their journey? How do you prioritize which hospitals, which departments get which digital products and services? And does this fall under Digital Health Governance Committee? Do you use a scoring mechanism? I mean, where do you even begin? What's the advice you have for people early in the journey?
Again, another great question. We have an engaged audience, which is I'm really happy about that. This is definitely one of the bigger pain points when it comes to this. Like, if it was up to me, I would fund and do all of these things that are listed here, right? But we can't. We know that you have to always pick and choose where you put your dollars to use. And that is why, yes, to answer the question, we do get this through our care delivery digital governance structure. We don't necessarily have a scoring system, but from all different service lines, we ask them to bring up their top 2 or 3 projects that they would want to do. We do tie it back in with the system-wide strategic priorities for that year. We tie it in with our system-wide quality initiatives and priorities for that year. If we want to bring our scores down for our sepsis numbers, or if you want to bring our length of stay down, then the initiatives that will be focused more on that will get a higher prioritization. Some of them, this also has to do with the maturity of your different, talking about a large healthcare organization, we are separated into regions. So one of our regions in the West is more mature when it comes to our telehealth capabilities because we've been doing it for a little bit longer. We have our virtual health specialists, so it's easier and more efficient to roll out products and projects onto that side. So that kind of maturity also comes into play. If you have an area in your organization that has already implemented or worked with some of these products, it'd be easier to implement that quickly, get it done. So it is a broad question. We are definitely deliberate about it. I don't think we have the best system because I don't think there is one best system, but having your senior leadership involved, having your senior leadership engaged in this process, and then making sure you keep your organization's overall strategic goals in mind when you're making these decisions will help you make effective decisions.
And we get this challenge and dilemma come up with so many of our health system partners that we actually designed a maturity model. And I think you used the word maturity a couple of times in your answer, Molly. And that was, of course, with input from our IT and clinical advisory boards. But they're kind of stages from, completely traditional care over, yesterday and all the way to this beautiful nirvana where everything is just seamless and happens effortlessly in an integrated way. And there are stages there. And I'm kind of doing this because I'm very spreadsheet, like they thought,
Yeah.
those are the columns. And then the rows, you must start with a problem that you're solving. And I liked what you mentioned, Malik, which was kind of an impact effort analysis of which problems to solve, and then the approach, but then the governance and the change management, not just, buy-in and change, but sustainability plan must be in place. And then what are the outcomes that you're aiming for? How are you going to measure it? Who's responsible for measuring it? And then after all of that is when you have to, as a last thing, the technology, pick and choose the technology that supports all that, rather than starting with the shiny object and saying, oh, there's this cool thing. What problem could we apply it to? It has to be just much more strategic. And we talked about that on our prep call. Dr. Khan, you said you like the shiny objects in your personal life, like the newest watch, and but in your professional life, you have to be a little more disciplined.
Exactly. That is absolutely true. And it is, and also when you are in leadership in telehealth, you will have your colleagues from the system, your friends come up with, hey, I've been talking to somebody XYZ, they're using this new robot, they're using this new technology.
Yeah.
I want that too, right? And then that is where some of the hard decisions have to be made that, yes, what kind of an impact is that going to have? Is that something that there are some things that organizations do that become like the poster child that is maybe does not have the impact that affects the breadth of the patients, but it becomes that one innovative thing or a couple of innovative things that you're the leader in. So absolutely. But overall, do not chase the shiny object. You said it very well, right? And it has to be a problem-based solution rather than a solution and then go look for a problem that it can solve.
Agree. Any other advice that you give to an organization, regardless of where they are in their journey? Early on, mid-stage, more, I won't use mature.
Well, I think that there's some really good market research lately that tells us that virtual care is a priority. AONL just published research where they they had 3,000 respondents who said that virtual care is their number one priority for
Mhm.
redesigning healthcare. We commissioned market research of hospital leaders, and 74% of them said that virtual nursing is their a top priority. But many are still stuck in pilot mode. And why is that? And I saw a really good report from McKinsey just in January of this year, and it's about AI adoption, but I think it applies to all of this. And they said that the biggest barrier to scaling is not employees who are ready, but the leaders who are not steering fast enough. And so it's our duty as leaders to have the discipline to make the tough decisions and to steer.
Absolutely. And sometimes it is going to be scary because it is transformational, right?
Yeah.
So,
Yeah.
and to your point, advice to newer or to organizations that are maybe just starting out in their journey towards formalizing their telehealth structures or leadership is make sure that your senior leadership is engaged. Traditionally, we are all used to just getting the work done and then hoping that we get recognition and it gets looked at and picked up and then it can be expanded. That is one way of doing things. But if organizations want to do this right, I think it has to have a clear strategic directive from the very top, the C-suite, and coming down. When you build structures from the top for telehealth, they will be much more efficient. You will be able to get some of those tough decisions and steer quickly, like Elizabeth mentioned, and then bring up the talent that you want from within your organization to help you build that up.
Well said. Well said.
That's great. I will say that from my standpoint and the conversation today with both of you, which was very rich and I very much appreciate it, is that it really underscores the fact that what we used to refer to as telehealth was primarily what we're doing right now with video. And that's great technology, but it's been around for a while. And we used to treat it as a sideshow within an organization. And now what you're saying and what you two are demonstrating through your work is that this is really very much part and parcel the fabric of how we're doing health and providing health to our communities. And so the success of it doesn't hinge on technology, to your point, Malik. It hinges on leadership. And not just individual leaders, but aligned leadership across the organization, so that the next era of hybrid, patient-centered, and digitally enabled care, it's there, it's going to evolve, but it's going to evolve only if we lead. So with that, I want to thank both of you for an incredible conversation. Thank our audience. We are going to have this recording made available to you. And I think we also, Elizabeth and Malik are both available to questions. We'll make sure that we get your contact information out there. So thank you both for your support of the work and leading the community in so many important ways. And thank you all for your time.
Yeah, thank you.
Thank you so much for having me.
Absolutely. Bye now.